Hi all. So today we are going to learn about anti-anginal drugs. What are anti-anginal drugs? These are drugs used to prevent, abort or terminate attacks of angina pectoris. So last year we had learned briefly about angina pectoris and myocardial infarction. Let's learn about it in detail. So angina pectoris is a pain syndrome due to induction of an adverse oxygen supply or demand situation in a portion of the myocardium. So there is myocardial ischemia which results in accumulation of metabolites and further elicits the pain. There are three types of angina. First is the classical variety. This is the most common form and attacks are provoked by exercise, emotion, eating and coitus. What is the underlying pathology? Here there is arteriosclerotic affliction of larger coronary arteries. This results in fixed coronary obstruction. The blood flow fails to increase despite the increased demand. The inadequacy of the ischemic left ventricle will raise the end diastolic left ventricular pressure from 5 to 25 millimeters of mercury. This causes subendocardial crunch and hence further aggravates the ischemia. The second type is variant or prinzmetal or vasospastic angina. It is an uncommon and unpredictable form. The attacks occur even at rest or during sleep. The underlying pathology is recurrent localized coronary vasospasm superimposed on arteriosclerotic coronary artery disease. The third type is unstable angina. There is rapid increase in the frequency and severity of the attacks. The attacks occur even during rest and sleep. The pathology is there is rupture of an atheromatous plaque which results in platelet deposition, occludes the coronary artery, reduces the blood supply, results in cardiac muscle atrophy and hence there is fibrous replacement which further results in cardiac arrhythmias. Coming to the clinical classification of anti-anginal drugs, it can be divided into two groups. First is the drugs used to abort or terminate the attack, that is sublingual preparation of glyceryl trinitrate and isosorbide dinitrate. The other group is used for chronic prophylaxis. Now here is a chart of the classification of anti-anginal drugs pharmacologically. The first is the group of nitrates. So among nitrates, glyceryl trinitrate is the prototype drug. Nitrates are divided into two types, that is short acting and long acting. So let us see how glyceryl trinitrate causes vascular smooth muscle relaxation. There are four mechanisms. One is preload and afterload reduction. Then comes redistribution of the coronary flow and it relieves the pain symptoms. Preload reduction is by venodilatation which results in peripheral pooling of blood, reduces the venous return and hence the end diastolic size and pressure are reduced. According to Laplace law, when the ventricular radius decreases, the tension or pressure onto the ventricular wall also decreases. This causes decrease in the oxygen consumption and cardiac output. Afterload reduction. This is by arteriolar dilatation, reduces the total peripheral resistance. The afterload on the heart also decreases. The systolic BP falls more than the diastolic BP and hence reduces the cardiac work. Redistribution. The nitrates preferentially relax the big conducting coronary arteries than the resistance vessels. Hence there is favorable redistribution of blood flow to the ischemic region. Mechanism of relief. The primary effect is reducing the cardiac work. By action on peripheral vasculature and increased blood supply, then the peripheral vasculature, that is bronchi, biliary tract and esophagus are also mildly relaxed. Now coming to the mechanism of action at the cellular level. In the smooth muscle cells, the organic nitrates undergo denitration. This releases a free radical called nitrous oxide, which activates guanyl cyclase, increases the levels of cyclic GMP, which reduces the calcium entry, and dephosphorylates MLCK, that is myosin light chain kinase, through a cyclic GMP mediated protein kinase. This reduces the availability of active MLCK, which interferes with myosin activation. Hence, myosin will not bind with actin, contraction is prevented and causes relaxation. Coming to the pharmacokinetics, the drugs are lipid soluble, well absorbed from the buccal mucosa, intestine and skin, extensive and variable first pass metabolism in the liver. Exception is isosorbide mononitrate. They have got longer T-half and, as said above, classified into two types, that is short acting and long acting. Some of the adverse effects are fullness in head, throbbing headache, flushing, fainting, palpitation and dizziness. Then very few rare adverse effects are methemoglobinemia and rashes. Tolerance. The sublingual type of GTN, no tolerance develops against this, but when GTN is given orally, the reactive oxygen species produced during denitration of organic nitrates inhibit the mitochondrial aldehyde dehydrogenase and nitrogen oxide or nitrous oxide generation is interfered. So the free radicals are not produced. This does not cause arteriolar dilatation. Hence, this can result in tolerance. But it can be prevented by providing a nitrate-free intervals every day. Dependence, sudden withdrawal of the drug after prolonged exposure can result in coronary and peripheral blood vessel spasm. This can cause MI and sudden deaths. Drug interactions, sildenafil and other PDE5 inhibitors cause dangerous potentiation of the nitrate action, that is severe hypotension. And when a patient who is receiving other vasodilators, when this person is given nitrates, it results in additive hypotension. Coming to the clinically used nitrates. First is GTN, that is a prototype, or nitroglycerin. It can be given as three different preparations: sublingual, transdermal and intravenous. The sublingual preparation is given to terminate or abort an attack. When anginal pain is relieved, the remaining part of the tablet may be spit or swallowed. Transdermal patch, it has got high bioavailability. It provides a steady delivery for 24 hours. The effect fades within 8 to 10 hours of administration. Hence, it is advised that the patch be taken off for 8 to 10 hours daily. IV infusion. Rapid, steady, titrable plasma concentration for as long as desired. The use is in unstable angina, MI, hypertension and LVF accompanying MI. Others used are isosorbide dinitrate, isosorbide mononitrate, pentaerythritol tetranitrate and erythritol tetranitrate. The other uses of nitrates are classical and variant angina, acute coronary syndromes, myocardial infarction, CHF and acute left ventricular failure, biliary colic, esophageal spasm and in cyanide poisoning. So the use of nitrates to treat cyanide poisoning is quite important. So here goes the mechanism. Hemoglobin, it first binds with a nitrate compound, that is sodium nitrite, to form methemoglobin. This, when combines with cyanide, forms cyanomethemoglobin, which further interacts with sodium thiosulfate to form methemoglobin and sodium thiocyanate, which is excreted in the urine. Now let's go on to the next group of drugs, that is beta blockers. It reduces the coronary flow by blocking the beta 2 receptors. Heart rate is reduced. This results the heart being in an inotropic state. The mean BP and cardiac work are reduced. Oxygen consumption also reduces. It is useful in decreasing the frequency and severity of the attacks. This increases the exercise tolerance in classical angina. It is used in unstable angina as well as NSTMI. Coming to calcium channel blockers, there are three types. One is phenylalkylamine, benzothiazepine and dihydropyridines. So the pharmacological action is basically smooth muscle relaxation with negative chronotropic, inotropic and dromotropic actions on the heart. On smooth muscle, it depolarizes by an inward calcium movement through the L-type channel, which is voltage sensitive. So this causes relaxation by decreasing the amount of calcium intracellularly. There is arteriolar dilatation. There is milder effect on the veins. DHPs have the most marked smooth muscle relaxant and vasodilator action. On the heart, it causes negative inotropic action. Except DHPs, all other calcium channel blockers have a negative chronotropic as well as a dromotropic effect on the heart. So in brief, how is the mechanism? L-type of calcium channels, they activate as well as inactivate at a very slow rate. So the calcium depolarized cells will have a lesser steep zero phase and refractory period. The recovery process results in a state from which it can be reactivated is blocked. Okay, the state is blocked by Deltasm and Verapamil. And Verapamil, it has another effect that it slows the sinus rate as well as the AV conduction, but Nephidipin cannot do this. DHPs are more selective for smooth muscle L channels. Let's learn about Verapamil. It causes arteriolar dilatation. It has got some alpha blocking activity and reduces the total peripheral resistance. Heart rate is reduced, AV conduction is slowed, but the cardiac output is maintained. Adverse effects include bradycardia, nausea, hypotension, and it can accentuate the conduction defects. Interactions: Verapamil shouldn't be given with beta blockers because it can result in additive sinus depression, conduction defects, and asystole. It increases the plasma digoxin level and can result in digoxin toxicity. So it cannot be administered in a person who is receiving digoxin. It shouldn't be used with cardiac depressants like quinidine. Now coming to Deltasm, it is a less potent vasodilator than Verapamil. It has got a negative inotropic action. It causes depression of the SA node and AV conduction. It dilates the coronaries. The adverse effects are, it is milder as compared to Verapamil, but it cannot be given to patients pre-existing sinus, AV nodal or myocardial disease. It increases the plasma digoxin levels, hence it cannot be given in a patient who is receiving digoxin. Now coming to Nephidipin, it is the first and prototype DHP. It has got a direct depressant action on the heart. The arteriolar dilatation results in decrease in the total peripheral resistance, hence BP falls. Rapid and short duration of action, that is 3 to 6 hours. Reflex sympathetic stimulation of the heart can result in tachycardia and increase the cardiac contractility as well as cardiac output. The adverse effects include palpitation, ankle edema, hypotension, drowsiness, etc. It has got higher mortality among post-MI patients and can be safely administered along with beta blockers and digoxin. Now the fourth one is Amlodipine. This is also a DHP. It has got complete and slow oral absorption, high oral bioavailability, vasodilation effects are lesser, volume of distribution and T-half is long. Nimodipine, it is a short-acting DHP. It penetrates the blood-brain barrier because it is highly lipid soluble. It selectively relaxes the cerebral vasculature. Hence, it is given in case of subarachnoid hemorrhage. Side effects include headache, flushing, palpitation, etc. Uses are angina pectoris, hypertension, cardiac arrhythmia, hypertrophic cardiomyopathy, and premature labor. In case of premature labor, we give Nephidipin. Coming to the drug combinations in case of angina pectoris. First is beta blocker along with a long-acting nitrate in case of classic angina, because tachycardia due to nitrate can be blocked by beta blocker, and the tendency of beta blocker to produce ventricular dilatation as well as to reduce total coronary flow can be blocked by nitrate. The second combination is of a slow-acting DHP with beta blocker. It has got the same advantages as the above combination. Now the third combination is nitrates along with calcium channel blockers. Nitrates can reduce the preload, whereas calcium channel blockers reduce afterload as well as increase the coronary flow. The beta blockers will help reduce cardiac work as well. Coming to the fourth group of drugs, that is potassium channel opener, Nicorandil. It activates the ATP sensitive potassium channels in smooth muscle membrane, thereby hyperpolarizing or relaxing it. It acts as an NO donor and hence causes arteriolar dilatation. It increases the levels of cyclic GMP. Venodilation is there. Preload and afterload are also reduced. The coronary flow is increased. It reduces the frequency of angina and improves exercise tolerance. There is a cardioprotective action, that is, there is ischemic preconditioning, that is activation of the mitochondrial ATP sensitive potassium channels. This results in brief period of ischemia followed by reperfusion. Now there are few important anti-anginal drugs apart from the given classification, that is dipyridamole and trimetazidine. Dipyridamole, it is a powerful coronary dilator. The total coronary flow is increased. Prevention of uptake and degradation of adenosine is what results in increased coronary flow. Dilates the resistance vessels and abolishes the autoregulation, but it has no effect on the large coronary arteries. Cardiac work isn't increased, venous return is not reduced, and the anginal symptoms are not relieved. Hence, dipyridamole, it exhibits a pharmacological success but a therapeutic failure. There is a phenomenon called coronary steal phenomenon. Here, dipyridamole dilates the resistance vessels in the non-ischemic zone. So this diverts the already reduced blood flow away from the ischemic zone, further accentuating or aggravating the ischemia. Coming to the second type, that is trimetazidine. It is a non-hemodynamic mechanism. It reduces the fatty acid oxidation and promotes glucose oxidation in the myocardium. So this is having metabolic effect on the myocardium. It reduces the frequency of angina and improves the exercise tolerance. Thank you.